Potassium is tiny but deadly. Let's break it down. Most potassium lives inside your cells, so about 98% of it. Only 2% of it is found in your blood. The normal range on your lab workup is going to be 3.5 to 5. And how do we get potassium? So diet, fruits, veggies, meats, obviously bananas, I feel like everyone talks about. And how do we lose it? Kidneys are the main route. You can also lose it in the GI tract from vomiting and diarrhea, and also you can have shifts in and out of the cells. The kidneys, especially the distal nephron under aldosterone control, are the main regulators of potassium. So what happens when potassium is low or high? Hypokalemia, low potassium, is less than 3.5. So whenever this is happening, you might have some muscle cramps, some weakness, some paralysis. Your heart might be throwing some PVCs. You might see U waves or be at risk for arrhythmias. And then hyperkalemia is anything greater than 5. With this, you might see muscle weakness, flaccid paralysis. Your heart, you might see peaked T waves, a wide QRS, or a sine wave, leading to the worst of it, cardiac arrest. All shifts in serum potassium is a big deal because it reflects intracellular stores. What are the risk factors for this? So CKD or ESRD, obviously, if our kidneys aren't working, we can't excrete potassium. It can be chronic or acute hyperkalemia. Also, ACE inhibitors, ARBs, and potassium-sparing diuretics like spironolactone increase your potassium. Insulin deficiency or acidosis shifts potassium out of cells, so this can lead to hyper-K. And then diuretics like loop or thiazide diuretics cause renal potassium wasting, leading to hypokalemia. Hyperkalemia in the ED is a big deal for me. Immediately on these patients, I'm getting an EKG and a VBG with lights because I want to know as soon as I can what that potassium is so I can start working to shift. In theory, you can act if the potassium is greater than 6.5, or if you see EKG changes, a rapid rise, or the patient's symptomatic. So the first step is going to be stabilizing the heart, and we do this with IV calcium. Why do we give calcium in hyperkalemia? Weird, right? Hyperkalemia makes cardiac cells more excitable by lowering the threshold for depolarization. So this leads to peak T waves, QRS widening, a sine wave, and then the worst of it would be cardiac arrest. Calcium doesn't lower potassium. It stabilizes the cardiac membrane, buying time until you can shift or remove potassium. Think of it as an antiarrhythmic armor for the heart. So how do we give it? There are two options. Calcium gluconate is preferred if you're giving it peripherally. I give 1 to 3 grams IV over 2 to 5 minutes. It acts in 1 to 3 minutes and it lasts about 30 to 60 minutes. So you buy yourself about an hour of time. This is safer for the peripheral IV because there's less risk of tissue necrosis if extravasation happens. And then calcium chloride is stronger because it has 3 times more elemental calcium than gluconate. I give 1 gram and this is over 2 to 5 minutes. Onset is immediate and this is so much more potent. This should be given through a central line because it causes severe necrosis if it extravasates. Shifting potassium into your cells is going to be your next step. So the way that you can do this is with insulin and glucose. This drives potassium into the cells. You can also give an albuterol neb, like a beta-2 agonist that drives the potassium in. You can give bicarb if they're acidotic. And then finally, you want to think about removing the potassium. You can do this with a loop diuretic if they're making urine, but a lot of these patients are ESRD and they're on dialysis. You can also give K-Xylate. K-Xylate takes quite a while. So usually I'm not doing this in the ER because it's really not going to help stabilize these patients. Hemodialysis is definitive care in ESRD in severe cases. So always be thinking about calling nephrology early. Looking at the EKG is really important. So EKG changes that you act on immediately would be peak T waves, QRS widening, or a sine wave. And then what about hypokalemia in the ED? So when do you act for this? This is at the potassium less than 3. They have symptoms, arrhythmias, or if the patient's on digoxin. Replacement for this would be oral potassium if possible. You can give IV potassium chloride if they're severe or symptomatic, and the max is going to be 10 milliequivalents per hour peripherally or 20 milliequivalents per hour centrally. You want to replace magnesium too. So hypomagnesemia makes hypokalemia refractory. So definitely be checking your mag level. And then on the EKG, look for U waves, ST depression, or arrhythmias. And really there's a fun way to look at EKGs. With a hyperkalemia, think about you're pulling from the T wave and you're kind of stretching it out. Whereas a hypokalemia, you're kind of pushing down on the T wave. Hyperkalemia kills quick. Think calcium first, then shift, then remove. Hypokalemia kills slower, but replace it before the arrhythmias show up. Potassium is small, but the stakes are huge.